I'm kind of what you would call an extroverted pathologist. Do you know how you can tell an introverted from an extroverted pathologist? When you meet an introverted pathologist in the hallway of the hospital, they look at their feet when they're talking to you. But when you meet an extroverted pathologist, they look at your feet when they're talking to you. No, I really am energized by the chance to be able to provide integrated diagnostics for the care of cancer patients, that I don't stop after I'm done making the diagnosis alone. And this whole story of going from reactive to efficient medical care has been highlighted in so many different various media. I mean, regular newspapers, magazines, TV news magazines, TV nightly news, this whole idea of doing tests and going from a phenotypic one type of therapy is good for every patient. If they don't respond, we go to the next level, and then if they don't respond, to the next level. And instead, we start to do efficient-based testing for predisposition, testing for screening, testing for diagnosis, prognosis, and response to therapy, and get patients on the right treatment, the right operation, the right drug, or maybe the right prevention, so they never get the disease in the first place. But there are a lot of parameters, a lot of very, very intense variables in play here. And it varies from the simplest pharmaceutical industry dynamics about the mergers and that type of thing, and expiring patents, and the grand desire to try to get a new novel agent from a biotech company into the pipeline of a big pharma. And we read about this, in the financial sections of our newspapers and on the internet every day. The economics have obviously changed. There's all sorts of issues of not only how much drugs should cost, but also how they should be paid for. At the same time this is happening, we have a whole different type of patient. We have patients who are much more informed. They have access to data that was never possible a decade or two ago. Via the internet and other electronic media, the patients are up to date. They question, they ask, what about this, what about that? And now they're starting to ask, why can't I get a therapy that's designed for me, for my tumor specifically, not for this disease you tell me I have, but for me. And maybe some of the more sophisticated patients are saying, and I want the therapy not just designed for my cancer cells, but also with my own genetic makeup as a person taken into account. So I won't get toxic side effects, and I'll get the maximum benefit from the available treatment for my disease. So when we add all this up together, we've got a very, very, very different place to practice than we did just a short time ago. Against this is this famous, and I say famous because it's not popular by Wall Street standards, of the failing productivity of the pharmaceutical industry. And as you look at this, you can see that as time has gone on from the mid-'80s to 2006, this goes up to, it's not changing, the amount of money spent in billions of dollars to achieve a new drug or to get a new chemical entity into patients in phase 1 trials is going higher and higher and higher and higher. Productivity has dramatically fallen, and you can see that. So let's talk now in this new personalized medicine era about breast cancer. Without a doubt, tests that drive therapy often appears first in hematologic malignancies, like lymphoma and leukemia. It often then translates, in my experience, sometimes into pediatric types of cancers and reaches solid tumors last. But the solid tumor it always seems to emerge first in is breast cancer. Not just because it's very common, not because it's easily accessible, that tissue from breast cancer is readily biopsiable, excised, and available for study, but because the disease is just so heterogeneous. We have absolutely 100 years of the Halsted mastectomy data. And in that 100-year period, from the 1870s to the 1970s, where the only treatment for breast cancer was a surgical radical mastectomy, as horrific that operation is considered today, it was the standard of care for almost a century. And that data told us that the disease was heterogeneous. We looked at the lymph node status in breast cancer and found that if the lymph nodes were not involved, the patient had about a 3 out of 4 chance that this disease would never relapse again in her lifetime. Surgery would cure her. And if the lymph nodes were involved, she had only about a 1 in 4 chance that the surgery alone would cure her. So here in this very common disease, we immediately had around 25% of the folks' favorite patients who were going to relapse and die. But there were also 25% of the patients in which it had already spread and theoretically shouldn't be curable, in which the surgeon alone was able to cure the disease. So we knew breast cancer was heterogeneous for 100 years, and then we developed the test to start telling us, can we pick out which patients in which group are likely to do this way or that way?